Hello and welcome to today's training on Management of Treatment-Resistant Depression with Dr. Charles B. Nemiroff, MD, PhD. This is the first professional webinar in our Depression Webinars series. I am Helen Heyman, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. You will also find all these tips in the attached go-to training guide we put together.
Okay.
We've taken a screenshot.
Okay, thank you.
Right. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio panel and the dial-in information will be displayed. Don't forget to enter your PIN. We will first kindly ask you to mute yourself so that we don't hear any background noise. To mute yourself, you will need to press the gray tab just below the red arrow. Kindly also switch off your webcam. The webcam tab is just below the mute tab. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. You will also be able to access materials. If you registered and pay for continuing education credit, you will first need to provide the 4-letter CE code on the webinar evaluation form. The link to the evaluation form in SurveyMonkey will be sent to you 48 hours after the end of the professional webinar. In order to obtain CE, you will need to answer the post-test assessment questions and obtain a score of 80% or above. In order to answer the post-test questions in the link you will receive 48 hours after the end of the webinar, you will see the post-test questions below the webinar recording. I would now like to introduce our expert. Dr. Nemiroff is the Leonard M. Miller Professor and Chairman of the Department of Psychiatry and Behavioral Sciences and Clinical Director of the Center on Aging at the University of Miami Miller School of Medicine. He is past president of the American College of Psychiatrists and the American College of Neuropsychopharmacology. His research has focused on the neurobiology of mood and anxiety disorders with a focus on the long-term consequences of child abuse and neglect and how these changes increase vulnerability for psychiatric disorders in adulthood. Dr. Nemiroff has published more than 1,000 research reports and reviews and 15 books. He is a member of the Institute of Medicine of the National Academy of Science. It is a true honor and pleasure to work with Dr. Nemiroff. I will now pass the screen along to Dr. Nemiroff.
Limited amount of time to talk to you about a very important issue in mental health treatment, and that's treating patients who are refractory to traditional treatments. By very nature, I'll be focusing on issues of diagnosis, issues of psychopharmacology, and I'll try to also include data relevant to psychotherapy because of its important role in managing depressed patients. These are my financial disclosures. All of my research is supported by the National Institutes of Health and by the Stanley Foundation. I have consulted to a number of companies and serve on a number of nonprofit scientific advisory boards, including the board of directors of the ADAA as well as the Scientific Council. So to start with, let's talk about diagnosis. And unfortunately, depression is a term that's often misunderstood by folks in the lay public. We all know that the word depressed is used broadly. I'm depressed if my sports team loses. I'm depressed if I don't get a great grade. But depression is a psychiatric syndrome. And as William Manchester said about Winston Churchill, who suffered from very severe melancholic depression, this quote, "All his life he suffered spells of depression, sinking into the brooding depths of melancholia, an emotional state which, though little understood, resembles the passing sadness of the normal man as a malignancy resembles a canker-sore." So I always tell the medical students and residents, if you think about the worst you've ever felt in your life and think about feeling that way every day, that's what major depression is like. I'm not going to bore all of you with the DSM criteria other than for you to recognize that DSM-5 is not terribly changed from DSM-4, and one has to have 5 of 9 of these symptoms for at least a 2-week period, as well as having a depressed mood. In my mind, the cornerstone symptom of major depression is relative or absolute anhedonia. That is the inability to experience pleasure. And I raise that because many of the patients who come to me labeled as treatment-resistant depression actually have another diagnosis. And the reason they haven't responded to treatment, in part, is because they have another undisclosed diagnosis, a severe personality disorder, comorbid drug or alcohol abuse, obsessive-compulsive disorder, or some other psychiatric syndrome. DSM-5 goes on to make a few other statements in terms of the diagnosis that I'd like to make some comments about, and one of which relates to the issue of hypomania or mania, which by definition would be change the diagnosis from major depressive disorder to bipolar disorder. This is a common diagnostic conundrum that I'm going to talk about later in the presentation. DSM-5 also distinguishes patient with specifiers, with anxiety, with mixed features, with melancholia, with atypical features. And when we talk about this, and also psychotic depression, these are important characteristics because this will also help drive our choice of treatment. And then there are specifiers for severity as well. Now, the major changes in DSM-5 related to previous DSM editions is one, bereavement has been taken out of DSM-5. And I just want to remind all of you that bereavement is a normal process that occurs after a very terrible and significant loss, such as loss of a parent, loss of a spouse, loss of a child. And in those cases, we expect patients to have symptoms similar to those that we see in depression. However, bereavement should be time limited, and in people who are vulnerable, bereavement can be replaced by an autonomous depression that does in fact need to be treated. And there are cultural issues related to the length of the grieving period, but as a clinician, it's something we should be alert to. DSM-5 also eliminated the chronic depression diagnostic category. So what you're looking at here are the spectrum of mood disorders, which range from the normal volunteers, who, and that's of course all of you on this webinar, who range in your mood from being slightly euphoric when good things happen and slightly down when bad things happen. But your range is relatively limited. And then you can compare that with these other pathological entities. And very briefly, you want to consider these when you see patients who come in complaining of depression. So dysthymia is a low-grade smoldering depression, as you can see here. And what distinguishes dysthymia from other mood disorders is that it's chronic. It tends not to be cyclic. And as one of my patients who had it once said, I've been depressed since I was a zygote. And these are folks who wake up every morning and they don't feel good in terms of their mood, and they don't tend to have any diurnal mood variation, and they tend to sort of have what we call the congenital blahs. Not a lot of data on treatment of dysthymia, largely a disorder that is relegated to treatment with various methods of psychotherapy, including CBT, although there are those who would suggest that SSRIs in low doses can be helpful. There's some data to support that, none of it FDA level approval. Psychothymia is a ill-defined condition in which patients presumably range in mood from mild hypomania to mild depression, very poorly characterized, no evidence-based studies on treatment of psychothymia, so we're not going to talk about it today. We are going to focus on unipolar depression, and we're also going to focus on making sure that the depressed patient who comes to see us does not have either bipolar 1 or bipolar 2 disorder, because the treatment of depression in those entities is markedly different than the treatment of unipolar major depressive disorder. So the first question when you evaluate a patient is, do they have major depression of the unipolar subtype? That is, are they possibly bipolar? And how often are patients diagnosed with unipolar depression who in fact turn out to be bipolar? That's a very important question. So I'd like you to look at some data. This is from Jules Onks, who's a very well-established psychiatrist in Switzerland. He has a mood disorders clinic, and these are the diagnoses of the patients when he first evaluated them at their very first visit at the mood disorders clinic. 92% unipolar, 8% bipolar. And the question is, what happens over time? Now, he has a mood disorder clinic, which by definition will draw patients who are both unipolar and bipolar, but the data is pretty startling that in his 30-year follow-up, the numbers changed dramatically. The keynote message here is that a very large percentage of patients who were originally diagnosed as unipolar turn out to be bipolar. And obviously, it's very important to know who they are. This data has been replicated over and over again. This is a psychiatric clinic in France, 250 patients. And again, those diagnosed with major depression, about a quarter turned out, in fact, to have bipolar disorder. So what are the clues about the possibility of diagnosing bipolar disorder in patients who present with major depression? First and most important is their own past history. And if possible, you'd like to get the past history not only from the patient, but from the family. Do they have a history of mania or hypomania? Second most important question, is there a family history of bipolar disorder? Because bipolar disorder is a genetically transmitted disease. 2/3 of the risk for bipolar disorder is genetic. And for that reason, you need to know whether there are bipolar patients in the family history. Now, please be aware of the fact that because patients don't read DSM-5, they might say Uncle Harry was admitted to a psychiatric hospital with schizophrenia, and that doesn't mean Uncle Harry had schizophrenia. He could, in fact, be suffering or had suffered with bipolar disorder. And then you should obviously try to use a screening test instrument for bipolar disorder. We like the Mood Disorder Questionnaire. It's a self-rating scale, which is an excellent and sensitive screening test for bipolar disorder. There are other clues to eliminate bipolarity in your differential diagnosis. Besides family history, bipolar depressed patients tend to have an earlier onset of depression, and in particular, if a patient tells you that they were depressed as a child, particularly prior to puberty, there's a very high likelihood that they, in fact, suffer with bipolar disorder. Psychotic depression often linked to bipolar disorder. Seasonal pattern is a clue, but perhaps the best clue is what I like to call antidepressant misadventures. If a patient tells you that they've been treated with an antidepressant and they didn't sleep for 3 days and they were agitated and hypomanic, then by definition they have bipolar disorder. You cannot convert a non-bipolar patient to bipolarity by giving them antidepressants. And as such, this is almost a provocative test for bipolar disorder. Now, it's important to also recognize that patients with major depression often have other comorbid diagnoses. These are the data showing how common this is. And as you can see, the common comorbid diagnoses are post-traumatic stress disorder and other anxiety disorders such as panic, generalized anxiety disorder, social anxiety disorder, and obsessive compulsive disorder. Know that patients who fulfill more than one axis 1 diagnosis, major depression, one of these disorders, are more difficult to treat and relative treatment resistant than patients with pure major depressive disorder. So in measuring patients' depression and their response, it's important to measure their symptom severity. In the same way that we measure blood sugar for diabetes, it's important to measure a depression symptom severity and how it responds to treatment, be that psychotherapy or psychopharmacology. For that reason, I tend to like self-rating scales. I tend to use the Beck Depression Inventory. I have my patients fill it out before every visit. One can use other self-rating scales, the Carroll scale, the Zung scale, or you can, in fact, use a scale in which you yourself administer it to patients and you measure their symptom severity. It doesn't much matter what you use as long as you use some measure. And then we follow the course of treatment using this schematic that you see here, in which patients come to you and they fulfill criteria for major depressive syndrome. As you can see here, you treat them with an evidence-based treatment, be it psychopharmacology or psychotherapy, and they start responding. And eventually you want to get them into remission, and we're going to talk about that in a minute. But remission is the absolute absence of any depressive symptoms, and a sustained remission is called recovery. And what we want to do is avoid a relapse and recurrence of their depressive syndrome. So these terms are used and sometimes they're ill-defined. So I want to spend a few minutes talking about definitions. Response is a clinically significant improvement in depressive symptoms. Remission is the virtual absence of any symptoms, a return to the premorbid level of functioning before they were ever depressed. Recovery is sustained remission, and we talked already about what relapse and recurrence is. So this is the gold standard and the goal of treating depression. This is what we want in all of our patients. And this is what it looks like on the Hamilton Depression Rating Scale, in which scores of 30 and above are very severe depression. And what we measure in patients over time is their symptom severity, and here's where we want them to be. We want them with a Hamilton Depression score of 7 or less, maybe even 3 or less. No symptoms of those 9 symptoms you know in DSM-5. We want them to be gone. We want to be really aggressive about treating depression. Why do we want to be aggressive? Well, first, it's a miserable state to be in. We don't want our patients to suffer. Secondly, if patients get better but they're not completely well, there's an increased risk of them relapsing, and the longer they're ill, the more treatment resistant they're going to be, the harder it's going to be to get them well. They're going to continue to suffer both psychosocially and occupationally, and therefore have decreased ability to work and workplace productivity. They also will overutilize healthcare services, which is not good for the healthcare system in general, nor for them. They will be at risk for both medical disorders. Depression is associated with a shortened lifespan due to heart attack, stroke, diabetes, and of course the risk for suicide. And suicide, as you know, all of you know, is in the top 10 causes of death in the United States, the only one in the top 10 causes of death that's increasing in number annually. So here's the data, a study by Michael Thace, showing that if you can get patients into remission, their chance of relapse over the following year is about 10%. But if they respond, that is, they get better but not well, their relapse rate is about 50%. And this finding has been replicated many times. So there's the morbidity associated with depression, the misery in terms of the symptoms, the effect on families, but then there's these data about how depression fundamentally shortens your lifespan by virtue of worse outcomes to heart disease, stroke, cancer, HIV, and other medical disorders. The longer patients stay well, the harder it is to get them well. And the more episodes they've had, the worse it is. We were able to show much higher remission rates to treating never treated depressed patients in the PREDICT study with both psychotherapy and pharmacotherapy than patients who have had multiple previous episodes. Other predictors of delayed remission are severity and with lots of anxiety. Older patients take longer to get better, and additional axis 1 comorbidity. So what are the obstacles to getting patients well? First, both patients and clinicians are often satisfied with just a little bit of improvement or some improvement, but not remission. So patients may be sleeping better, they may have an improvement in mood, but they still may have problems with concentration, they may still have crying spells, they may still have suicidal ideation. Another obstacle are the side effects of the medications that we give them. Another obstacle is being able to afford treatment, either psychotherapeutic treatment or psychopharmacological treatment. Some patients are underdosed. They may be getting a medication dose that's within the accepted dose range of the medication, but it may be an underdose for them. But the big issue is for the patient and for the clinician to recognize the residual symptoms. How do we increase the likelihood of remission? Measuring symptom severity so we know what the outcome is, selecting the right treatment, making sure that patients are taking their medication, or for psychotherapy, making sure that they are adhering to both the appointments and to the homework in the case of, for example, cognitive behavior therapy, and the combination of pharmacotherapy and psychotherapy that many of these patients require. Now, depression, as you can see from this slide, is primarily a female disease. 2/3 of the risk for depression is, in fact, in women, 1/3 in men. The increase in the risk in women occurs after puberty, as you can see here, and there are several peaks during the reproductive years. That's partly due to the risk of depression during pregnancy, in the postpartum period, and of course in the perimenopausal and postmenopausal times. Each of these forms of major depression needs special treatment. I won't have a lot of time to go into this today at all, but women during the reproductive years who particularly suffer with depression during pregnancy, in the postpartum period surrounding miscarriage, or in the perimenopause ought to see an expert who specializes in treating women during these years. I want to distinguish between premenstrual dysphoric disorder, which is very common. As you can see here, that is a worsening of mood symptoms during the premenstrual period, and true severe late luteal phase dysphoric disorder. So I like my female patients to fill out a mood chart, and as you can see here, this is an example of classic premenstrual dysphoric disorder. All of the patient's symptoms cluster premenstrually. The circles up here are the dates of the menstrual period, and you see all of these symptoms, both mood symptoms and physical symptoms, occur premenstrually. The rest of the month is clear of symptoms. But I had a patient come to me who said, I'm suffering with premenstrual dysphoric disorder, and the patient's pattern looked like this. And you can see here are the days of the menstrual period. Yes, there was premenstrual worsening, but look at the rest of the month. This is clear major depressive disorder with anhedonia, sadness, feeling overwhelmed, difficulty concentrating, lack of energy, a problem with sleep. This is major depressive disorder. So we're going to subtype depression because it's going to affect treatment, looking at atypical depression, looking at psychotic depression. Those are the two subtypes that have the biggest yield in terms of designing specific treatments for them. Now let's talk about treatment and treatment resistance. We have a panoply or a menu to choose from psychotherapy, of which several forms of psychotherapy have been shown to be effective, CBT and IPT to a lesser extent, but some data, psychodynamic psychotherapy. And then we have ECT, light therapy for seasonal affective disorder, transcranial magnetic stimulation and vagal nerve stimulation, both approved by the FDA, deep brain stimulation, not yet shown to be effective, and a variety of antidepressants. In terms of antidepressants, we're going to pick them on the basis of this algorithm. Safety, we have to know what other medications the patient is taking for other disorders, tolerability, efficacy, cost, and of course simplicity of dosing. And the STAR-D study, which has gotten lots of attention, it's now more than 10 years old, treated everybody with an SSRI, citalopram. And the data were quite startling. So the patients were treated with citalopram and then switched to either another antidepressant, bupropion, or cognitive therapy, or sertraline, or venlafaxine, or augmented with other agents. And those who failed these treatments went on to additional treatments. And what startled all of us in this study was that the remission rate for treatment with an antidepressant, citalopram, an SSRI, was only 33%. That meant that 67% in this open study of patients actually turned out to not be in remission, which meant that the antidepressant in this totally take-all population in the real world with comorbid substance abuse, medical disorders, anxiety disorders, did pretty poorly. As you can see, in each step of the STAR-D, more patients did get into remission. So those who failed citalopram went on and were treated with buspirone or bupropion. Substantial number got into remission. Those who failed those two levels were treated with venlafaxine, bupropion, or sertraline, and you can see that venlafaxine actually was the best, but many patients got better. If you failed all of those treatments, you could see thyroid hormone augmentation or lithium helped some people, then a tricyclic antidepressant, and then eventually combination therapy and a monoamine oxidase inhibitor. Take-home message, you can never give up in treating depression. We have a lot of potential treatments. But we have to worry because of the high suicide risk. And patients, the longer they're depressed, the more treatment resistant they become. So what are you to do? Here you are on the highway and you're trying to figure out, if you're a psychopharmacologist, what am I going to prescribe a given patient? And in spite of what has been claimed by a number of companies, there are no diagnostic laboratory tests to predict antidepressant treatment response. In spite of what you've been told about these genomic tests, the data are not sufficient to drive you to predict whether a given patient will respond to venlafaxine or paroxetine or sertraline. So the first thing you're going to do is reconfirm the diagnosis. Are you sure that they really have treatment-resistant major depression? Do they have any other psychiatric conditions like PTSD or OCD? Do they have hypothyroidism, the #1 medical cause of resistant depression? Or do they have a vitamin D deficiency? For men, do they have a testosterone deficiency? All of these need to be corrected because that will enable patients to have a more likely response, and sometimes just fixing the medical condition will in fact treat their depression. And have they had a really adequate trial in the past? And most importantly, are they taking the medication? Now, one of the biggest predictors of treatment resistance is childhood maltreatment. So it's important that you get a child abuse and neglect history, because patients who have this history will have a more significant and worse course of depression, and they show a poorer response. And this slide shows you that in response to psychotherapy, pharmacotherapy, and combined pharmacotherapy, psychotherapy, there's virtual universal agreement that patients with a child abuse history have a poorer treatment response to treatment, those who are depressed. So what do you do if somebody fails an antidepressant? You can give them another antidepressant in the same class. Sometimes that works because these drugs are not the same. So you can switch from fluoxetine to sertraline or paroxetine or S-citalopram. You can go across classes, say, well, I treated the patient with a serotonin drug, now I'm going to use a serotonin norepinephrine drug, or you could add another treatment, either psychotherapy or pharmacotherapy. The advantages of switching is the patient's on only a single agent. The disadvantage is you have to taper the patient off the first medication and then begin the second medication and titrate the dose. Whereas augmentation or combination, if they've gotten some better with the treatment they're on, then you could add something which hopefully will help them further improve. This is an old study from Michael Thace. I subsequently did an even larger study showing that at least head-to-head, venlafaxine, the SNRI, might be a more effective antidepressant getting patients into remission than the SSRI, In this case, a combination of SSRIs were studied, but most of this was fluoxetine. But the pooled analysis did show that venlafaxine was, in all likelihood, slightly more effective in getting patients into remission. But if the patients fail antidepressants, you have the opportunity to add psychotherapy, and I'll show you some data for that, or you could add one of these agents that have been reported to convert antidepressant non-responders to responders. So this is what you're going to be thinking about moving forward. You can optimize the dose they're on. Are they having any side effects? Could they tolerate a higher dose? So perhaps for escitalopram, go to 20, 30, even 40 milligrams. If they're not better, should I switch to another agent, or should I add a second antidepressant or an augmenting agent that in itself isn't an antidepressant but can bring them into remission, or should I move to electroconvulsive therapy or repetitive transcranial magnetic stimulation? One of the oldest augmenting treatments is thyroid hormone. It has virtually no side effects, 25 to 50 micrograms. It's worth a try. It had clear efficacy in the STAR-D study, not used very much anymore. It's cheap, and it's definitely worth trying. Lithium, the second evidence-based augmenting strategy, actually discovered one of the few treatments we have that was discovered due to a basic neuroscience investigation. Lithium enhances the effects of antidepressants. And pretty good data, as you can see here, that patients treated with tricyclic antidepressants who failed, these are their Hamilton scores, before treatment, 48 hours after lithium addition, 300 milligrams 3 times a day, this tremendous antidepressant response. Lithium not used very much anymore because of concerns about side effects, but quite frankly, compared to some of the antipsychotic drugs that are used for augmentation, can be less burdensome in terms of side effects and just as effective. And this is a summary for all of you of the lithium augmentation data. Virtually no studies that have shown a poor response to lithium augmentation. What about atypical antipsychotics? They're the most common strategy to convert antidepressant non-responders to responders. First study ever done, 8 patients in green treated with antidepressants. You can see they were all quite depressed if you look at their Hamilton scores. Then they were given a low dose of risperidone, and all 8 of these patients had a phenomenal response, as you can see here in orange. And that led to several controlled studies. There's a study we did many years ago showing patients who had a history of non-response to antidepressants treated with citalopram, no response at all, then augmented with risperidone, and you see this response. But notice the final HAM-D score, a MADRS score, is about 12, which is not in remission. Some of the patients got into remission, others didn't. So, big effect of risperidone augmentation added to citalopram, placebo alone, no effect. And then if you follow these patients for 6 months, which is what we did, you could see that risperidone augmentation in beige here prevented their relapse, slowed the relapse compared to placebo, but after a 6-month period, the 2 lines meet, and there was a substantial risk of relapse of about 40%. Here's the data on olanzapine. Unfortunate side effect profile, causes a lot of weight gain, but in this 8-week double-blind trial, you can see that these were the fluoxetine monotherapy. You see no response. Then you see fluoxetine plus olanzapine, you see this very sustained response, and this sustained response continued for 16 weeks. So there's no doubt that olanzapine, which is FDA approved as an augmenting agent in combination with fluoxetine, is effective. Ziprasidone, another antipsychotic, is effective, as shown here, added to sertraline, but it is not FDA approved. There are two other antipsychotics that are approved to convert antidepressant non-responders to responders. They include aripiprazole. This is my own study with my colleague Jeff Simon, case report showing this phenomenal ability of aripiprazole to take antidepressant non-responders. You see this remarkable effect. This led to a double-blind, placebo-controlled study, which patients were randomized to aripiprazole plus antidepressant or placebo plus antidepressant. And you can see in these two studies a very, very clear separation between placebo augmentation in gray and antidepressant, this aripiprazole treatment in red. So clearly efficacious, but again, look here at the remission rates. So treatment-resistant patients for which placebo is added have remission rates about 15%. When aripiprazole is added, it goes up to about 25%. But that's not great. 75% of the patients still didn't get into remission on a combination of aripiprazole plus an antidepressant. Here's the scorecard for many of the antipsychotics, all of which have been shown to be effective. But again, many patients don't get into complete remission. And the problem, of course, is you end up with more side effects when you add antipsychotics to antidepressants, as shown here. This is the data with the latest antipsychotic, brexpiprazole. You see clearly superior to placebo in treatment-resistant patients when added to an antidepressant. And this is effective in actually two different doses, 1 and 3 milligrams. I'd like to show you some pretty exciting data from Jan Fawcett, one of our leading investigators out of New Mexico, showing that high doses of a drug called pramipexole, which is FDA approved to treat restless leg syndrome and Parkinson's disease, is actually quite effective in converting antidepressant non-responders to responders. And he looked at a combined group of bipolar depression, unipolar depression, 20 patients, and 12 of them had an excellent response to pramipexole. And these patients had failed multiple treatments, including antipsychotics. If you're going to use pramipexole, you should start at a low dose, about somewhere, I like to start at 0.25 milligrams at bedtime and then get up to about 1 milligram. Some patients need to take about 3 milligrams. Monoamine oxidase inhibitors are the oldest antidepressants. They are available generically. We do have to adhere to the dietary guidelines and make sure that the patients don't have untoward drug-drug interactions, particularly effective in treatment-resistant atypical depression characterized by hypersomnia, extreme rejection sensitivity, and anxiety. Let me skip that for time. You can combine two antidepressants with different mechanisms of action, such as mirtazapine and bupropion, mirtazapine plus an SSRI or an SNRI. And the slide set which you have documents the efficacy of this combination treatment. I do want to talk about psychotherapy. In a chronic depression study we did comparing antidepressant nifazodone versus CBT in chronic depression, we found equal efficacy of the antidepressant and psychotherapy, as is shown here, but the combination was more effective. And the take-home message here is combination psychotherapy and pharmacotherapy is more effective than either alone. Now, this is the latest randomized study that's been published looking at treatment-resistant patients. It's a VA-based study. It was just published in the Journal of the American Medical Association, and I just thought I'd take a minute to describe it to you. Big study, 1,500 patients who were refractory to antidepressants. They were switched to bupropion, an FDA-approved treatment, augmented with bupropion so that they stayed on the antidepressant they were on and received bupropion, or they stayed on the antidepressant they were on and received aripiprazole. So what did the results show? First, the group that was switched to bupropion, a quarter of the patients, and they were mostly on SSRIs, a quarter of the patients got into remission on bupropion alone. For those who stayed on the SSRI and had bupropion added, the remission rate was about 27%. And then for those who were augmented with the SSRI plus aripiprazole, about 28.9%. The take-home message here is that, in fact, all of these patients get into remission. You just have to study this in a stepwise fashion, and we didn't have any prediction of response. So I want to finish up and talk a little bit about psychotherapy and a little bit about non-pharmacological treatments. I want to leave some time for all of you to ask me questions. So what you're looking at here is, again, a very recent study that looks at cognitive behavior therapy added to patients who are treatment resistant to medication. These were 80 patients, 78 were randomized to either supplemental CBT or not. And as you can see, it was a very, very significant effect here of CBT added to the antidepressant in these treatment-resistant patients. And I want to show you the data that compared to antidepressant treatment and treatment as usual, which involved some supportive psychoeducation, you could see that the cognitive behavior therapy group plus the antidepressant clearly has an advantage. So that highlights my point about optimal treatment is truly combination antidepressant cognitive behavior therapy. I don't have time to talk about ketamine. These clinics are springing up all over the world for truly severely treatment-resistant patients. These are the data that have shown it to have some efficacy. As you can see here, it's an intravenous infusion in these two studies I just showed you, and a third study published a couple of years ago, as you can see here. I would implore you all to read this meta-analysis that we published in the October 2015 issue of the American Journal of Psychiatry, and the JAMA psychiatry piece 2 months ago where our APA task force gave recommendations. Lastly, I just want to remind you about electroconvulsive therapy, still considered the most effective treatment for treatment-resistant patients. And I want to remind you that transcranial magnetic stimulation, often called ECT light, is FDA approved for the treatment of depression as well. And these are the data that led to the FDA approval of RTMS. Finally, there was a paper published in the New England Journal of Medicine about 3 weeks ago in which the use of direct current therapy, which is something that you could find on the internet, was compared with escitalopram, and the finding showed that this was not, I repeat, not an effective treatment for depression. So that's the data that I'm showing you here. Vagus nerve stimulation, finally, is a surgical procedure that is approved for the most treatment-refractory patients. So I'm going to stop here. I did want to leave time for questions. I know I went through this material very quickly, but I want to thank all of you for taking time out from your very busy schedule to join me.
Thank you very much, Dr. Nemiroff, for this excellent presentation. As a reminder to everybody, please start sending in your questions to the chat panel so I can share these with Dr. Nemerov. We have a couple of minutes for questions.
Don't be shy.
Dr. Nemerov, I think there seems to be some interest in knowing more about the ketamine study that you were sharing. Could you perhaps elaborate on that a bit, please?
Absolutely. Let me go back to the ketamine slides. So ketamine is an anesthetic agent that's approved by the FDA. It is also, unfortunately, a drug of abuse and the #1 drug of abuse in Asia. So because it's FDA approved, any physician can administer it. There have been about 300 patients who have taken part in one or another trial of ketamine, which is a very small number compared to what the FDA would in fact want before they would approve a drug for treatment. So we have this data, as I'm showing you right now, of efficacy for about 3 days in this study after a single intravenous infusion. The thought is that ketamine works on a receptor called NMDA receptor. A second study, again, showing in these very refractory patients, you can see that placebo had no effect. But part of the problem with these studies is you can't blind patients to the treatment because an infusion of saline can easily be distinguished from an infusion of ketamine. But again, you see in this study, the antidepressant effect lasted for a few days, but notice at best the MADRS score is still 20, which is still very depressed, but less depressed, of course, than 30. An attempt was used to use midazolam as a control because, you know, this is a benzodiazepine. It does have an effect. And as you can see, ketamine was shown to be more effective than midazolam. So we did a meta-analysis of all of the data up to the time we submitted this to the American Journal. And what we suggested was there's no question it has a transient but clear antidepressant effect, but we were concerned about abuse liability. We were concerned about neurotoxicity after chronic use, but maybe we were learning something about mechanism. And that's why we did this analysis and suggested certain guidelines. So there are some very reputable ketamine clinics in the United States where you get worked up by a psychiatrist. They tell you about what all the FDA-approved treatments are for depression and would recommend them to you. And if you have failed many of those and wish to get ketamine under controlled circumstances, then it will be administered. There have not been a lot of studies about what to do after that first week when you've responded and now relapsed. So how often can you get ketamine is a very significant question, and is it safe? Johnson & Johnson is doing studies with S-ketamine, which is an enantiomer of ketamine, and they have some very positive data in the public domain. And there are a number of pharmaceutical companies that are looking at drugs that may have effects similar to ketamine without the psychotomimetic effect. So it's an evolving story.
Thank you so much, Dr. Nemerov. We have here another question. Are there any studies on the combination of mindfulness-based therapies, namely MBCT or MBSR, and antidepressants? So I can repeat.
No, that's fine. So mindfulness, you know, depression is a disease that has to be managed, and there are a number of treatments that can be brought to bear, all of which can be helpful. So we'll start with exercise. There's pretty good data that exercise is very helpful in mild to moderate depression. This is the work of Jim Blumenthal at Duke, but there are others who have looked at this as well. However, severely depressed patients, the data on exercise is not compelling. First, it's hard to get those patients to exercise, and when one does, the effect on depression is relatively minimal. So what other treatments are there to bring to bear? One of them is mindfulness. There's pretty good data from folks in Toronto and in Pittsburgh that mindfulness can be an important component of the armamentarium that we have to treat depression, that mindfulness can in fact augment the effects of antidepressants, of other forms of psychotherapy. I think the database isn't as robust as I'd like it to be, but certainly it should be considered a component.
Thank you very much, Dr. Nemiroff. I think there would also be a question about the efficacy of TMS in treating treatment-resistant depression.
Okay, so our TMS was originally approved by the FDA for patients who had failed one, but not more than one, antidepressant treatment trial. Since then, the FDA has changed the label to approve it for patients for depression regardless of their past history. So there have not been a great many controlled trials of our TMS, but and they certainly have not been focused on severe treatment-resistant depression. So one of the issues of our TMS is that the patients come and get treated 5 days a week. The average treatment takes about 37 to 40 minutes. And they're sitting in a comfortable reclining chair. There are those who have suggested that in addition to whatever therapeutic effect it has, that there may well be a sort of placebo response associated with the treatment, and it's usually over a 4 to 6 week period. And my feeling about that is I don't care whether the patient's responding to the active treatment or to a placebo effect as long as they get better. So what there hasn't been, which this question begs, is has anyone ever taken treatment-resistant depressed patients, randomized them to transcranial magnetic stimulation versus ECT, and then seen if our TMS stands up as well against ECT, because obviously it has fewer side effects, it doesn't require general anesthesia, etc. But there is no such data to my knowledge.
Thank you so much, Dr. Nemiroff. I see we have a final question, and here's our question. Dr. Nemiroff, you spoke about not having any genes of response for antidepressants. Can you please comment on pharmacogenomic tests that include genetic markers for metabolism?
Yes, so in the spirit of true transparency, I am chairing the APA task force on biomarkers and novel treatments. And we have just completed a review of all of the commercially available tests that claim to predict antidepressant treatment response as well as side effects. And that report is just being submitted for publication to the American Journal of Psychiatry. So I can't let the cat out of the bag other than to give you my own personal view, which is the genetics of the enzymes that metabolize drugs, the cytochrome P450 system, can, in my looking at the evidence, be helpful in predicting side effect burden of antidepressants that are metabolized by those enzymes. However, I don't believe that the claims, and this is my own personal opinion, that there is sufficient evidence that has accrued to suggest that the claims of one gene or another polymorphism predicting antidepressant response, I don't believe that there's sufficient evidence to support those claims. But that's a personal view of my own. I am agnostic on the issue and more than happy to see additional data because if such data existed, nothing could be better than having a laboratory test that would predict antidepressant response the way we have a laboratory tests to predict response to certain forms of, for example, breast cancer. So I think that is the future of psychiatry. The published database, in my mind, isn't there yet.
Thank you very much, Dr. Nemiroff, and thank you to our participants for attending today's webinar. You will receive a follow-up email within 48 hours that includes a link to the evaluation and a link to the recording of the webinar. Thank you for taking a moment to share your feedback with us. Please visit our professional development webinar site to view the other upcoming webinars in the depression series. And we hope you will join us at the Anxiety and Depression Conference 2018 from April 5th to 8th in Washington, D.C. On behalf of ADAA and our presenters, thank you for joining us today and have a great rest of your day.